Good morning. The topic of this presentation will be screening for post-stroke atrial fibrillation and use of anticoagulation therapy. As you all know, stroke is one of the leading causes of death and disability worldwide. It was estimated that up to 20% of patients with ischemic stroke have a previous history of atrial fibrillation. However, the incident rates also is noted that rise sharply with aging. For example, in stroke patient older than 80 years of age, the incidence of AF-related stroke has increased 3 times during the last 35 years. And it was estimated that it will be another 3-fold increase in the stroke rate after the 2050. That's why, despite the advancement in medical knowledge, the cause of ischemic stroke remains unclear in approximately 1/3 of cases. Detection of atrial fibrillation is of central importance after stroke or TIAs, as risk of recurrent ischemic stroke can be effectively reduced by oral anticoagulation like warfarin or NOACs. Regarding classification of cardiac rhythms in patients with stroke and TIAs, there are 3 broad categories of cardiac rhythm in patients with stroke. Patient with no AF, patient with no AF, it means patient with diagnosis with AF before stroke onset, and this diagnosis is based by ECG, and it was reported that in this patient there was high burden of AF with high prevalence of vascular risk factors and structural heart disease. Also is worth noting that AF detected on admission ECG and during some acute illness like systemic infection or of pulmonary embolism equal the risk of non-AF. For us, the most important in third category, it is AF detected after the stroke onset. This is atrial fibrillation detected during short-term Holter monitoring or during the prolonged cardiac monitoring after the occurrence of stroke or TIA in patients without history of atrial fibrillation. On the right part of this slide, you can see the relative frequency of various heart rhythms in patients with ischemic stroke. It was shown that, reported that in the 80% of patients without known atrial fibrillation from their history, about 24% with eventually will be diagnosed with atrial fibrillation after the stroke. The burden of atrial fibrillation after the stroke is the total amount of time spent on atrial fibrillation during prolonged cardiac monitoring, and it may reflect the severity of underlying cardiac myopathy. By consensus minimum AF duration threshold for diagnosis of atrial fibrillation after stroke is by ECG more than 30 seconds, but it was different for implanted cardiac devices. In that case, cutoff is longer than 2 minutes because it was determined by AF detection algorithms by their machines. It was shown also that patients with AF after the stroke have increased risk of death and dementia compared to patients without AF. That's why the embolic risk of atrial fibrillation after stroke can be understood as gradient defined by prevalence of vascular comorbidities and the severity of atrial cardiomyopathy. On this slide, you can see on the left part of this slide characteristics and outcomes of atrial fibrillation after stroke versus the known atrial fibrillation. You see the difference between demographic and risk factors, vascular comorbidities, and cardiac and cerebral structural changes. Based on this huge meta-analysis by Friedman and his co-workers, these differences translated into lower CHA2DS score and 26% lower risk of recurrent stroke for patients with atrial fibrillation after stroke compared to the patient with known atrial fibrillation. The most important markers reported by various clinical studies consistently associated with diagnosis of atrial fibrillation after stroke are age, left atrial enlargement, increased cardiac natriuretic peptides, and premature atrial complexes. It was shown also in several studies that stroke risk in patients with AF with previous stroke is approximately 3 to 5 times higher than in patients with stroke without stroke but with similar vascular comorbidities. Atrial fibrillation consists of spectrum of phenotypes with varying degrees of embolic risk. Based on the ASSERT and IMPACT clinical trials, there are three mainly subtypes of atrial fibrillation after stroke. First is early high burden or type A atrial fibrillation, which is usually detected within the first days after the occurrence of ischemic stroke. This kind of atrial fibrillation may have the similar risk profile to non-atrial fibrillation. And in all studies, it is thought that it's probably cause of ischemic stroke. Second, in remote low burden or type B atrial fibrillation, which is usually detected beyond 3 months after the stroke onset. And it is the most frequent type of AF after stroke detected by prolonged cardiac monitoring. It was thought that it is a possible bystander AF, but we are not still sure. And the third is early low burden or type C atrial fibrillation, which usually occurs within the first 2 weeks after the stroke onset. This kind of AF does not usually recur or can recur in isolated low burden paroxysms. And these paroxysms are thought that usually are incident AF. Very briefly about the concept of cryptogenic strokes. In all patients with ischemic strokes or TAs, after the initial workup, there is still a substantial number of patients with unknown cause. Study reported that this number is up to 33 all patients with ischemic stroke. Among them, there is a category of patients with neurological signs that are consistent with embolic source of their strokes, and this kind of possible embolic strokes are named ESUS strokes, and they comprise about 60% of all ischemic strokes. However, recently published Arcadia clinical trials is fourth randomized trial that didn't show the benefit of NOACs compared with aspirin in patients with this concept of ESUS cryptogenic stroke. And maybe it's time to say goodbye to this concept. Very briefly, which system we use for prolonged AF screening? It is considering the continuous rhythm monitoring lasting less than 7 days is short-term cardiac monitoring. And the main strategy for long-term monitoring is to increase the probability of detection of paroxysmal AF in patients with cryptogenic strokes. Current methods of ECG monitoring include invasive and non-invasive methods, and clinical studies show the device with the highest proven yield in detecting AF are implantable cardiac monitors and implantable loop recorders. The use of prolonged cardiac monitoring in patients with stroke or TAs should be based on three main premises. First premise is that prolonged monitoring increases the detection of AF. And really, randomized clinical trials show the detection of atrial fibrillation is proportional to the duration and intensity of cardiac rhythm monitoring. Also, clinical trials showed 5 to 6 times increased rate of detection of AF in patients with post-cryptogenic ischemic stroke with implantable cardiac monitors or external loop recorders compared to the standard of care monitoring. Second premise, that the detection of AF leads to the administration of anticoagulation to reduce the risk of recurrent stroke is also proved by several clinical studies. However, the third premise, that anticoagulation reduces the risk of recurrent stroke in patients with AF detected on prolonged cardiac monitoring, is still unknown. And 2 recent meta-analyses didn't find any statistical significant difference in risk of recurrent stroke between prolonged and standard of care monitoring, but there are several explanations for that. We are still waiting for a result of ongoing FIND AF2 trial, which will include more than 5,000 patients with cryptogenic strokes. The best duration of extended ECG monitoring after acute ischemic stroke is still unknown. Based on AHA guidelines for management of acute ischemic stroke, duration is still uncertain. But European Stroke Organization guidelines recommend implantable loop recording more than 48 hours in patients with cryptogenic strokes. The results of 2 large randomized clinical trials, EMBRACE and CRYSTAL AF, suggest that approximately 10 patients need to be screened with prolonged monitoring to detect one patient with AF. But we must bear in mind that several randomized studies show that prolonged ECG monitoring by implantable loop recording produce higher detection rate of AF, not only in patients with cryptogenic strokes, but also in the patient with other causes of stroke, for patients with large atherosclerotic stroke and patients with small vessel disease stroke. For example, in stroke AF trial, detection rate of atrial fibrillation after the stroke was 12% after the 12 months of prolonged cardiac monitoring. On this slide, you can see result of several studies with rate of detection of AF with implantable cardiac monitoring in patients with cryptogenic stroke. And it is clearly visible, that statement, that with prolonged use, we can detect more patients with atrial fibrillation in cryptogenic stroke. But what to do if we find atrial fibrillation after stroke? There are several knowledge gaps regarding this issue. First, which duration of atrial fibrillation is associated with an increased stroke risk? We don't know this for now. What is the temporal relationship between AF and stroke? In this regard, there are several clinical studies which use implantable pacemaker could help us. This study shows that first 5 days after multi-hour episodes of AF seem to be most relevant. Also, this trial showed that asymptomatic AF longer than 24 hours are much more important for stroke recurrence than atrial fibrillation with less duration. Also, what level of burden of AF increased stroke risk? We still don't know which level is important to initiate anticoagulation in those patients. And finally, do we have to treat incidental bystander with lifelong anticoagulation therapy? We must always judge the risk of anticoagulation versus severity of potential embolic stroke. We know from the clinical experience that patients with cardioembolic stroke has much more severe stroke compared to other types of strokes. For illustration, I will show you the findings of Nordic atrial fibrillation study, which was recently published. It was investigated in Norway and Denmark, and they include patients with cryptogenic stroke, but after only very extensive diagnostic workup. For example, their inclusion criteria are patients with TIAs with MRI-proved diffusion weight lesion. In that way, they want to avoid any patient with misstroke diagnosis. Also, in all their patients, they do TEE in patients younger than 65 years of age. This is very comprehensive and very detailed done diagnostic workup for cryptogenic stroke. And based on this study, they implant a loop recorder, but important to know that implantation was done by stroke physician, because we know that it is very simple procedure to implant a loop recorder in patient, and with that they avoid prolonged time to start monitoring, and they achieve timing less than 2 weeks after the onset of stroke to start long-term cardiac monitoring. And they found that in this patient with cryptogenic stroke, 29% had episode of AF. It is important that in 93% of these patients, this episode were completely asymptomatic. On the upper right part, you can still, unfortunately, that in more than 50% of these patients, extensively investigated patient, cause of their cryptogenic stroke was unknown. On the lower part, you can see the comparison between detection rate in several similar studies that use prolonged cardiac monitoring, and they use detection rate duration longer than 2 minutes for detection of AF on prolonged cardiac monitoring. Considering anticoagulation in this group of patients, first to see what we should do with patients with AF detected with unselected diagnostic methods. In this patient, oral anticoagulants were associated with 40% lower adjusted risk of stroke recurrence and almost 30% lower risk of death, with no difference in incidence of intracerebral bleeding. Also, one observational study reported 40% lower adjusted risk of dementia in patients with ischemic stroke with AF after the stroke onset. However, data from Canadian Stroke Network show us that only less than 1% of all stroke population receive at least 48 hours of Holter monitoring within the first 1 month after the stroke onset. And we can say that in this group of patients, anticoagulant use and lower risk of stroke and dementia is likely driven by non-prolonged cardiac monitoring detected atrial fibrillation, which likely represent high burden AF and is associated with more cardiovascular comorbidities. The second group are anticoagulation patients with prolonged cardiac monitoring detected atrial fibrillation. Studies show that individuals undergoing prolonged cardiac monitoring are more likely to be started on oral anticoagulation than those receive standard of care. For example, in that Nordic AFib study, almost 97% of patients with detected AF were started on oral anticoagulation. Recent meta-analysis, including more than 1,000 patients with cryptogenic stroke, found a significant 55% reduction of relative stroke risk in patients with ischemic stroke associated with prolonged cardiac monitoring. The associations between prolonged cardiac monitoring and lower risk of ischemic stroke recurrence may have been stronger if we limited our approach to patients with AF detected in patients with high risk of AF burden and with a high risk of future cardiac embolism. This underscores the need for a more personalized selection of patients who are most likely to benefit from oral anticoagulation. Why is this important? Because the risk of ischemic stroke depends on the interplay of well-known risk factors. And that's why recently Sposato and his co-workers proposed stratified approach. They call their approach bad risk AF DAS score, which should help us to estimate better risk of stroke recurrence. This score is similar to, for example, a ROPE score that is used for the estimation of recurrent stroke risk in patients with PFO. Because the ultimate goal is to identify the patient at low risk who may not benefit from anticoagulation in the time of diagnosis of their AF, but who would still require a close follow-up because AF burden is generally progressive state and the prevalence of risk factors and comorbidities increase with age. However, not all patients with AF detected after stroke need anticoagulation because the risk should be high. It was estimated that annual risk of stroke in patients with AF should be more than 0.9% to warrant use of NOACs or more than 1.7% for use of warfarin. However, all neurological and cardiological guidelines recommend starting anticoagulation in patients with AF and stroke. But this is regarding only patients with non-AF. We are talking now of patients with AF detected on prolonged cardiac monitoring. Why is this important? Because initiating oral anticoagulants after brief paroxysmal in people at low risk could result in misleading sense of safety if competing mechanisms are not investigated or left untreated. We know that all types of strokes or causes of stroke share the similar cardiovascular risk factors. Also, the prevention of atherosclerotic disease associated ischemic stroke require antiplatelet agents, which also can increase risk of intracerebral bleeding by sometimes 37% if we concomitant use NOACs. Of course, there are several other scenarios that we could imagine with this approach. Very shortly about this new proposed term of atrial high rate episode in patients with prolonged cardiac monitoring. This is actually atrial tachyarrhythmia that was discovered only on prolonged cardiac monitoring. And their causality is not completely known, but it was presumed for now that they could be precursor of AF. And European cardiology guidelines recommend that we should consider use of anticoagulation in selected patients with high or very high risk of stroke, and they mainly use CHA2DS score for estimation of that risk. This is recently published pathway in EuroPace 2023 about decision process for considering anticoagulation in patients with atrial high rate episode detected on prolonged cardiac monitoring. There are actually two studies that explore the issue of use of anticoagulation in this population. First is Noach's AFNET-6 study, which compare use of endoxaban and placebo or aspirin in this group of patients. However, this study was terminated prematurely because they found increased risk of bleeding in patients with endoxaban. But for now, result of this study didn't show any significant difference in the rate of stroke in patients on anticoagulants versus patients on aspirin. Second is ongoing Artesia clinical trial, which compare use of apixaban and aspirin in this group of patients, and the result will be shortly presented in the American Stroke Scientific Session, maybe next month. And as conclusion, we could say that atrial fibrillation detected after ischemic stroke is not a benign cardiac arrhythmia. Evidence up till now suggests that it constitutes a distinct and heterogeneous type of AF, but with an overall found lower risk of ischemic stroke than patients with AF before stroke occurrence. Whether anticoagulation reduces the risk of recurrent ischemic stroke in all or some patients with AF detected after stroke or TIAs is still unknown. But better understanding of interplay between atrial fibrillation burden and other factors known to influence the stroke risk is crucial to better identify low risk and high risk patients for better management and for use of probably anticoagulation. Stratified approach might help to better estimate the risk of stroke recurrence and better guide decision-making use of anticoagulation by using the personalized prevention strategy. Thank you very much.